Welcome to The Explainer. Today we're unpacking the incredible journey of a transplanted kidney. We're going to go from the moment it's on the surgical table all the way through the crucial years of care that come after. Most of us think the surgery is the finish line, but for a kidney transplant patient, it's really just the beginning. The real work, the real challenge is the years of constant, vigilant monitoring needed to protect that incredible, life-changing gift. So this is the condition we're talking about. The reason a transplant becomes absolutely necessary. And it's a game changer, offering a quality of life that long-term dialysis just can't match. So let's get into exactly how it all works. All right, first up, let's talk about the procedure itself. It's a surprisingly elegant surgical solution that gives patients a whole new start. Okay, so here's something you might not know. Surgeons usually just leave the old failing kidneys right where they are. The brand new kidney gets placed way down in the lower abdomen, and this placement isn't random at all. It's super deliberate. It's close to the surface, which makes it incredibly easy to check on with a doctor's #1 tool, the ultrasound. So, the new organ is in its new home. Now what? How do doctors actually know if it's happy and healthy? How do they check its vital signs? Well, it all comes down to listening to the kidney's pulse. They measure the blood flow to get this crucial number called the resistive index, or RI. It's just a brilliant, non-invasive way to peek inside and see exactly how that new kidney is settling in. Think of it like this. A healthy kidney is basically always on. It's constantly filtering blood. That means it has really low resistance, so blood flows into it super easily, both when the heart is pumping and when it's resting. But if that kidney gets sick, say from an infection or rejection, it swells up. And its outer layer, its capsule, is really tight and unforgiving. So that swelling literally squeezes the blood vessels inside, which jacks up the resistance and makes it much harder for blood to get in, especially when the heart is resting. And it all boils down to this one number, an RI above 0.7. That's the universal red flag. It doesn't tell the doctors exactly what the problem is, but it's like a big flashing alarm that screams, hey, something's wrong in here and you need to figure it out now. Okay, let's zoom in on those first few weeks right after the operation. This is the critical period where doctors have to troubleshoot some of the most common early problems. What's really fascinating is that the timing of a problem is a massive clue. Different complications have a habit of showing up in these really specific windows after surgery, which helps the medical team narrow down the possibilities pretty fast. So this chart basically breaks down the 4 usual suspects when fluid starts collecting around the new kidney. Each one has its own signature. You've got your hematoma, which is just an internal bruise. A urinoma is a urine leak. A lymphocele is a buildup of lymph fluid. And an abscess, well, that's an infection. By looking at what the fluid is, and just as importantly when it shows up, doctors can get to the bottom of the problem. Now, one of the biggest head scratchers for doctors early on is telling the difference between acute rejection and something called acute tubular necrosis, or ATN. Rejection is pretty straightforward, right? It's the body's immune system attacking the new organ. But ATN, that's more like shipping damage. It's harm caused by a lack of oxygen while the kidney was being transported, that cold time it spent on ice. They can look really similar, so a biopsy is often the only way to know for sure. All right, next up, we have to talk about the plumbing. The arteries and veins connecting to the new kidney are its absolute lifeline, so making sure they're working perfectly is critical. So doctors are really on the lookout for 2 main artery issues. The first is thrombosis. That's a complete blockage, and it's a massive surgical emergency. The second, and way more common, is stenosis. That's a dangerous narrowing, usually right where the new artery was connected. And a huge clue for that one is when the patient suddenly develops high blood pressure that's really, really hard to control. And check this out. This shows a beautiful but really dangerous visual clue for something called a pseudoaneurysm. It's a weak spot in an artery wall that can sometimes be accidentally caused by a biopsy needle. As blood swirls in and out of that little bulge, it creates this perfect yin and yang pattern on a color ultrasound. It's a crystal clear sign of trouble. This is the calling card for a renal vein thrombosis. Just try to picture this. The main drain pipe leading out of the kidney is completely blocked by a blood clot. The pressure inside gets so intense that when the heart rests, the blood trying to flow into the kidney actually gets pushed backward. Seeing blood flow in reverse, it's just a dramatic, unmistakable sign of a major, major emergency. So we've made it through the surgery and the first few rocky weeks, But a successful transplant isn't the end of the story, not at all. It's the beginning of a lifelong journey of really careful management. You see, even with all those powerful anti-rejection drugs, the immune system can be stubborn. Over many months and years, it can keep up a slow, low-grade attack. This leads to scarring, a gradual decline in function, and, yep, you guessed it, that telltale rise in the resistive index all over again. And here is a truly staggering, tough reality. The very same drugs that are absolutely essential to stop the body from rejecting the new kidney can increase the patient's risk of developing certain cancers by as much as 100 times. That's just an incredible number to wrap your head around. And this is exactly why that long-term follow-up is so intense. Doctors are constantly walking this tightrope. They have to suppress the immune system enough to protect the kidney, but not so much that it opens the door for cancers or for opportunistic viruses like the BK virus to wake up from being dormant and attack the new organ. So in the end, a transplant isn't really a cure. It's more like a trade. Patients trade one set of life-threatening problems for a new but lifelong journey of vigilance. It's this constant partnership between the patient and their medical team, using all this incredible technology to guard that precious gift of life. And it really leaves us with a key question for the future of medicine. How can we protect the organ